session because we are joined by Rachel House. And tonight, Sarah will become the main moderator, and we're going to be joined by the founder of Rachel House, Tantalina. So thank you, Tantalina, for joining our session tonight. And we also want to welcome all participants who have just joined. We hope that tonight will bring you a lot of insights, particularly on how to deal with your work coworkers, as well as how do you deal with the environment around you related to the pandemic right now. So Sarah, I'm going to invite you to start the session tonight and to open our webinar tonight.
Hello, good evening, everyone. Thank you for your participation in this session. So this session will be from 7 p.m. to 8:30 p.m. We start a little bit early because we usually start at 8 p.m. Jakarta time. So just a short rule about the webinar. So if you have any questions related to the main topic, you can type it in the Q&A panel, or you can chat it directly to me or Anastasia or Sean, who's also here to join us. And other questions unrelated to the topic, you can also write it through the chat panel. We will answer your question at the end of the sessions. But however, today's session will be more of like a discussion where we talk back and forth and conversation. So if you have any question in the middle of the session, feel free just to type it on the chat panel. The materials will be sent through your email after the session starts. Okay. So to start tonight's session, actually, today's title is about adapting to a pandemic, which is what we have to do, right? Since 6 months ago. It will be very, very interesting. However, I am obliged to introduce you first about the House of Analytics and Rachel House as well, who is our guest tonight. So House of Analytics is an analytics innovation lab which focuses on extracting unique insights from business data. So we help businesses take different approach to exploit their full potential, not only looking at the conventional solutions, but also looking at the experimentation and other ways where we can, how can we solve the problem and what to do with the data or with the situation that we're currently facing. So tonight, as mentioned with Tasha's before, it is a very special night because tonight we're joined by Lina Chandra, the founder of Rachel House, Yayasan Rumah Rachel House, and she will be giving us a short story about Rachel House itself, which has pioneered children's palliative care in Indonesia. And me as well as moderator, my name is Sarah. So I've also been exposed mainly in the area of human capital analytics, financial analytics, working for the House of Analytics. However, one interesting fact about both me and Lina here. So Lina used to be majoring in finance or business, but now she plays a huge role in terms of healthcare. While me, I used to go to dentistry for university, and now I work in a business and management industry. Okay, so to adapt in a pandemic, about the crossing between the design thinking in terms of providing healthcare in time of COVID, especially in Indonesia. Here we invite Rachel House, who has been a very, very great help to Indonesia healthcare since 2006. So Lina, would you kindly share about Rachel House? What did you do in Rachel House and what is Rachel House? So the audience here will be more familiar with your backstory.
Thank you, Sarah. Good evening, everyone. Thank you to House of Analytics for inviting Rachel House to be part of this discussion. And I'm looking forward to a more sort of open discussions later, but perhaps to begin with, a little bit about Rachel House. So Rachel House was founded in 2006, and it's an organization that at that time in 2006 and still today pioneered children's palliative care in Indonesia. And we are set up to look after children who are living with life-limiting and life-threatening illnesses like cancer and HIV. So I know in the mind of most people that we talk to, usually the question comes up, what is palliative care? And palliative care is a line of medicine that provides symptom management and symptom management and emotionally, physically, or psychosocially for people who have been diagnosed with terminal illnesses, with the sole focus of improving their quality of life. And so in our mind, it would be, how would you improve somebody's quality of life? For us in palliative care, it means that whatever symptoms that a patient or a person is showing, we're there to make sure that we keep those symptoms at bay. Whether the symptoms is physical or emotional or spiritual, we are there to make sure that we tackle each one of them. Because I think when we go to most of the medical care, you're there for the physical symptoms, but often what is unsaid and what is the greatest suffering, perhaps, it's also your emotional pain. So palliative care looks at how we can improve the quality of life of a patient so that they have a better, optimal time with their family for whatever time they have left. So in Indonesia, why do we start palliative care and why do we start Rachel House? Statistically, there's about 700,000 children living with serious illnesses in Indonesia. And when definitely, even right now, less than 1% have access to palliative care. And when we began in 2006, when we had our first patient in 2008, a lot of our nurses would come into patients' home, because this is what we do. We provide home care. We would come into patients' home with screaming children from the house, heard by our nurses arriving in their motorbike. Why? Because pain is something that, in the early days at least, is something that the medical world does not treat. They believe that pain is part and parcel towards curative care, so there's nothing to be done. In fact, if you were to treat pain, you may lose your guidance to how to cure the patient's illness. So we've come a long way today. Now most of the hospitals in Indonesia, or at least in Jakarta, I won't say in Indonesia, most of the hospitals in Jakarta have doctors and nurses who are exposed to the theory of palliative care and approach of palliative care. And I think with the drum that we continue to beat is that we may not be able to cure a lot of the patients who as we know, come from very far from the rural area. By the time they come into the hospital in Jakarta, curative treatment may no longer be available. But our reason for being is that no one should actually live with pain untreated, because we may not be able to add days to their lives, but we can definitely add life to whatever days that they have remaining. And this is the principle that we live by. This is our reason for being. And I think it's worth actually stating that in this day and age, when we have all of the money, all of the technology, all of the skills to actually bring care to patients, one of the best tools that we have is to make sure that they don't suffer. And suffering, pain at all levels, whether it's physical or emotional, is suffering. So this is the role of Rachel House, and that's what we've been doing in the last, I guess, 14 years.
So from the perspective of palliative care, how do you see healthcare in Indonesia in general?
Big question, Sarah. Indonesia has a very complex situation. And I think the only country that in Asia that I often liken this to or compare that with is actually the Philippines, and not India, but Philippines, because we have how many thousand islands in our archipelago, and many rural areas have insufficient population numbers for the government to actually be able to set up a hospital to take care of those patients in the rural area. And so this leaves a lot of the people in a rural area unattended and with little access to doctors and to proper healthcare. That's why Jakarta becomes the go-to place when, patients have been diagnosed with cancer or have symptoms that their rural doctors can't cope with. So that's the one difficult situation that we face in Indonesia. The second, we have insufficient number of doctors, at least in the rural area. Jakarta, we're lucky. I think we have much higher number of doctors per population, and almost to the tier of some of our neighboring countries. But this is definitely not the case for everyone else other than in Jakarta. So the big question, if I were sitting in a government, would be how can we entice doctors to basically be able to serve in the rural areas? What are the trade-offs for doctors to basically be willing and able to go to the rural area and serve? There are some of the doctors that I've spoken to who are young and passionate and really want to go to the rural area to serve, but often come back after a few months because they are so thoroughly disappointed, heartbroken, because their presence could not bring relief to their patients because they were not equipped with the tools to bring proper care to their patients, right? So it's a catch-22 situation, right?
Yeah. I agree, because I have a lot of friends who need to go to rural areas in order to get their license to practice in Jakarta, right? However, it's not that they don't want to serve. It's more like a lot of equipments are not there, and then even though when they want to serve, the people there also have different perspective of care. Some of the people in a rural area doesn't believe in doctors or in modern medicine, for example. And then not to mention that even when they go there, sometimes they want to treat the patient but they just can't, right?
Yeah.
And this is, of course, this correlates strongly with the palliative care, right? Since Jakarta is a place for people to go to, and then a lot of people who had cancer in RSTM, right? There's everyone from all Indonesia there. And it really needs the human touch in terms of treating the patients. It's gonna be very hard if you try to explain, if you try to treat people from maybe outside Jakarta or from a culture that you're not familiar with about it. And then this is very interesting about the interesting thing about the palliative care, of course, because palliative care is here to help the patient to add life to their remaining to their remaining days. However, of course, it must face some challenges. That is inevitable, right? When you come to do house visit, and then maybe the patient treat you differently because not familiar with their usual doctor, they cannot accept the fact that, oh, I'm in the palliative care, not in the curative state anymore. So how does Rachel House deal with these challenges?
Yeah, that's great answer. Great question, Sarah. So there are different levels of your questions. One is cultural, and Indonesia, once again, hundreds and thousands of different culture. Even within one sort of South Sumatra, you'll have so many different languages and different way of conducting your ritual and what is important for you. And I think this is where palliative care training becomes really important for healthcare workers. One is the ability to ask questions. And if we each take ourselves back to our interaction with doctors, whether in hospital setting or in a clinic, how many times have you ever heard a doctor say to a patient or to you or to anyone that you know, what is important for you? And may I know that, if this happens, are you willing to trade off? What is your trade-off? What is the most essential thing for you as we go through some of this treatment for you? And I think for palliative care, that's the key question we ask. And if not in that direct question, it will be in getting to know our patient and their family first. So getting to know the family, getting to know the patient's way of living, it's really important. And this is also an added benefit for our team because we are actually a home care team. So we work with our partners in the hospital. When patients are referred to Rachel House, our team will go to the home. And sometimes even if we were to meet the patient at the hospital setting first, we will sit with the parents and to make sure that we know how many caregivers are there for this child. Is the mother alone most of the time? And if the mother is alone, is there a neighbor that she can count on? If there are no neighbors that she knows, because often there are people who have come from out of town and they're renting a place. If there are no neighbors, who actually gives her the time for relief? Now, the reason why we ask that question is we want to know if you're too tired to take care of the patient of the child, then we know that our patient will not have an easy time. So making sure that you are taken care of as a mother is equally important for us as it is to take care of our patient. So therein lies the difference between palliative care and perhaps other lines of care. And I hope one day that this approach of making sure that all healthcare workers understand first and foremost what's important for patients and their families becomes something that's not only in palliative care, but is everywhere, because I think that's really important. The other thing about how it is difficult now more than any other time. It was difficult before in a hospital, but even now, even more so now during the pandemic, is to actually be able to sit with the patient and to touch.
Yeah, I agree.
Because, touch is such a powerful thing, even if you just touch somebody's shoulders. And I've seen, when we started learning palliative care, we brought in a lot of doctors from overseas and nurses and also social workers. One particular visit was a visit by a group of 3 doctors, 1 social worker, and 2 nurses. And we took them to a cancer shelter where there were I think 25 kids with 25 mothers, all waiting to see these group of doctors. And one mother had just had her child assessed by one of the doctors. And the child has this really big growth on his face. And he was I think 3 or 4 years old, but a really sprightly kid. He was his mother kept asking him to wear a mask because, because otherwise the wound is pretty scary for everyone. But he kept taking it off and he said, "Why are you ashamed of me?" Now, for the mother, after the doctor had turned around to look after another child, the social worker who was standing beside the mother just touched her shoulder and rubbed her on her shoulder. And that mother just started pouring with tears. So the power of the touch is really powerful. But how many of us have read all the news that we see today that COVID patients are dying alone, and healthcare workers are devastated that they can't even touch the patient and they can't even open their mask so that, as a human to human, we can actually be with that person on their last breath. So I think we often take for granted during the time before the pandemic that touch is always there. But Sarah, touch was not always applied, right? I think we all know that we don't have a lot of doctors who actually touch the hands of the patients. It's really important to also understand cultural. We've had patients who have come in from outskirts of Indonesia, and while they're in a hospital, the father would be squatting right in a corner of the room. And when one of our doctors from overseas squatted down, knelt down, and asked for an interpreter to speak to the father and asked, "How long have you been here?" The father started crying because he said, "I've been here for a month, but nobody speaks to me." And this is where I think a lot of us, as you said, at RSJM have patients from all over Indonesia, different culture. And sometimes only a father can afford to come with the child, and sometimes, another family members. But we have lost the ability to, in all of our busyness, to try to cure. We have lost our antenna for that human suffering. And
Actually,
more important than any other time, I think, is the time of pandemic.
yeah, I agree, because when back in my days when I have to when I was stationed at RSTM, right? So
Ah,
every day I have to come there at 6 a.m. every day to help the polyclinics and then
yes.
everything to get ready, right? To get the bed ready and everything. And then uh even when I arrived there 6 a.m. to do hospital rounds, to do visit, there is always
A
this
queue.
yeah, there's always a queue, and there will always some people who has been there since 4 a.m.
Yes.
just waiting to the clinic to open so they can be the first one going to the clinic. And I'm not blaming the doctor as well, because there are tons of patients and they really have to manage their
Yes.
time really really good, just in order to cure everyone, because it's almost impossible to cure everyone. Like for example, if you go to maybe the hospital in Pondok Indah, right, or in like private hospital, you can just call and then you come 5 minutes right before your time, and then you will spend like half an hour or maybe 15 minutes talking to the doctor, and the doctor will assess you completely. But in bigger hospitals, especially for patients who are have really
BPJS.
really BPJS patients, and then people who have really really difficult case that they need to go to a specific hospital, for example. They cannot do that because the doctor already only have like 3 to 5 minutes to treat them, because they have tons of people queuing up, right?
Yeah.
And the touch part is actually really important, because if, let's say, at the end of the day the clinic is closed and there's still one or two patients that they have been waiting since the morning, but they still cannot get in because administration stuff, or some people he or she needs to do different tests before they go for the treatment. The doctor can be there and like touch the shoulder and say, I'm sorry, you cannot go here, but I can come to your room later, or you can go here at the beginning of tomorrow really early, we will serve you first, or something like that. However, it's very hard in pandemic, because you cannot touch, even if you cannot even see someone face to face apart from your face mask or your face shield, right? And in palliative care, this is something that mandatory to touch, because you need to calm the patient down. You need to be there for the patient. So how does Rachel House adapt or manage to keep serving the patients, to keep helping the patients in this pandemic?
So perhaps we need to sort of, I can share what things have been like for us right from the beginning of March.
Mhm.
When the first 2 cases in Jakarta was announced, or in Indonesia was announced, there were fears everywhere, right? There was fear, panic. It's almost like finally our son is no longer working to prevent us from getting, because initially it was the son of Indonesia that was actually stronger. But finally it's no longer true. And I think that threw everybody off, and including our team. Particularly our team, who basically go to some of to the poorest area, most crowded area to see patients with cancer and HIV. They're a two-way street. How can we make sure that we don't bring the infection into the homes of patients? And how can we make sure that our team is safe? And so initially what we did was we realized with all of the fears ramping up within our team, that the best way is to bring everybody into the room to talk about what are the fears, because fears can actually create a molehill, a mountain out of a molehill, right? A small thing can be blown up if we don't have the right information. We don't know if we can trust the organization to look after us, and we don't know if the organization will survive. And so we needed to bring everybody in to discuss, and for them to have an open discussion as to what's your biggest fear. And we had everything from, I'm really afraid for my parents who live really far away in Papua, but I don't know what to do, because gates were beginning to be closed in and people were beginning to talk about the inability to travel. And so we heard about some of our kader who said that actually our children and our family really want us to go back to the kampung because they said it's safer. And there was no right or wrong. everybody needed to be able to voice their fears, and all of those fears needed to be heard. And I think it's important for us then to also, being in a leadership position, to say, we don't have an answer for everything. What we know is that nothing has changed in the sense of our first responsibility is to keep you safe. And then what we need to do once we keep you safe is to see how quickly can we then look after our patients to make sure that they too have a way of access to care. Because nothing has changed. These patients are still suffering just because of pandemic, and the virus is now COVID-19 being on the front line. Doesn't mean that people with cancer and HIV don't suffer. And that remains true. So what we did then was to actually open up the discussion, had incredibly truthful discussions. We don't pretend that we can solve all the problems, but we commit to coming up with an infection control protocol that everyone feel somewhat safe with. And with whatever information that we have, we gather the support of Singapore doctors, basically overseeing all of our infection control process, because they were 2 months ahead of us, right? They had their first COVID patients much earlier than Indonesia. And so we brought them in to basically help our team set up the infection control protocol. Now, not everyone feels safe.
Yeah,
Because not every one of our team feels safe to go out. So I think that's the time when it's okay to do baby steps. It's okay to say, okay, let's try. And luckily for us, Sarah, we had a couple of our team who have been with us for longer than a decade. And they are really the ninjas, right? They are the people who sort of say, okay, we go out and we are willing to try it out. That's one. Two, making sure that we scout the environment to also speak to all of our partners, our partner hospital, our doctors, friends, and finding out, what is everyone seeing? What are we seeing in the field? What are we seeing in the hospital? What are we seeing in the way people are coping with it? And keeping in touch with everybody. I've kept in touch with even CEOs of companies to find out, what are you saying to your people? How are you coping with this? And what is the way to basically make sure that people feel comfortable with this? And so that is really important. I was sitting here in Singapore while the rest of the team was actually down in Jakarta. And I think this feels a little bit more at a distance because I needed to trust the people in the field. I often liken this to the time, a wartime, a general where you need that open communication for your soldiers to keep telling you what they're seeing so that you can actually equip them with whatever tools that they need to continue to function. But that open communication, I think, is so important. So I feel the key to our initial approach to this was being empathetic with what is there, what are people feeling, that nothing is wrong, nothing is right, and to also be able to be truthfully honest with your team to say that I don't know the answer, because we are about to sail in the most uncertain waters in our lifetime. So I think it's really important for us to be truthful and for both parties to be able to trust one another. And so I think in our way of actually initially coping with that, it would be understanding that we're all in this together and understanding that everybody agrees on what is the main purpose of why we're here. We're here gathered together because there are children who are suffering, and therefore by hook or by crook, we will try whatever we can and whatever is most safest for our team to still be able to go out there. So we converted our service really quickly. We had a phone call, phone consultation, video consultation, and then a home care that we mobilize when we can't solve the problems.
Yeah, so this is actually one of the questions that one of the audience asked in the chat. How does Rachel House manage to combine online and offline service? Because of course, when oh, I'm feeling a little bit sick and you want to do online consultation with your doctor, you can just like, doc, I'm feeling a little bit sick. Should I drink this? Should I do this or not? However, in palliative care, the symptoms is much more complicated. A patient can feel oh, I feel sick, but they don't know where that is. I just feel my body hurts a lot. And I feel nauseous, but I don't know what to do or something like that. How does Rachel House manage between offline and online interaction for the patients?
So one of the unique situation for our patients, and I think it's not unique, but it's not unique in Indonesia, but it's unique for perhaps our circle of audience here, is that a lot of our patients actually don't own digital phones. And so in the beginning of this pandemic, one of the first things that we had to do was to actually figure out who has digital phones that will allow us to be able to do video calls if we give them data package, and who doesn't have digital phones that we need to actually deliver digital phones. So that was the first level, right? And so first tools had to be made equal for everyone. And then we needed to basically train our caregivers for our children, and some of our children are babies, so we can't actually ask them, where do you feel the pain? So initially we had to pilot out having all of our nurses, this is also their first, to do video consultation, is to be able for them to tell parents, now if you were to touch the stomach in this area, does the child wince with pain? And so there needed to be a training, and all of that was a little slow in the beginning, and our nurses needed to be comfortable that they are actually assessing, and there was a lot of frustration. A lot of our nurses are saying, it's not the same, right? And then most of our patients' homes are really dark. So how do you assess oral hygiene? Like a lot of our patients, by the time that they're at the final stages of their cancer or HIV, will tend to have a lot of mouth sores, candida. So how do we assess candida for a patient who lives in a really, really dark place? And we can't use torch because they don't have a torch. So our nurses came up with this idea. They started buying this YouTuber's light that you can do a USB to the phone and then shine into the mouth. That helped maybe about 40-50%, but enough for us to basically be able to say, okay, this child needs, Nystatin, or basically a better oral hygiene care. So that's the online bit. Now, when it comes to then changing the tube, feeding tube, changing catheter, when it comes to a child that has incredible pain or wounds that are basically, dressings that needs to be changed or wounds that are festering, then we have no choice. Our team has to go out. Now, going out means that our nurses are dressed in full PPE. Then we face a challenge. Some of the families said, look, in the past, when you used to come into our home, you came in as a family members because you don't wear uniform.
Yeah.
And so none of our neighbors know that our child has HIV, and that we won't be discriminated. Now, if you start coming in with PPE, one, people will think we have COVID, and there is a risk that we may be evicted, or that they know that, oh, your child who is always malnutrition, who looks really thin all the time, who is sickly all the time, ternyata, in actual reality, that the child actually has HIV or is very, very sick with infectious disease. Now, there is this huge fear of discrimination. So that was an added challenge for our team. So that then led us to the decision, how do we break this? Initially, we pulled back. We're like, we don't know what to do. Then we started calling some of our partners, and we realized that the best way to do it is to figure out, can we actually do rapid tests for our patients? Now, this rapid test kits thing is relatively new, right? We only people start buying it only maybe the last 2 months. So initially we needed to learn, like, how do we navigate this? And it was heartbreaking for some of our nurses when they realized that they couldn't break that impasse, because when the patients say, no, we can't let you come with full PPE. And for us at Rachel House, we say, well, we don't know how to break this, because if we send you out, we don't know whether you'll be infected or not. So there was initially this heartbreaking time for our nurses because they've grown close to the children and yet they couldn't get out.
That's very true, because even though, let's say, as a healthcare worker, you have this service attitude to to be able to help all of your patients. Of course, you also have fear about yourself, right? What if I get infected? But especially about the COVID, no one knows whether you get it or not until it's too late initially, right? People who came in
Yeah.
for COVID is like basically they already have difficulty in breathing and they pass away within 2 or 3 days, and you cannot do anything to it because we're also new to the virus. Right?
Or some of our nurses actually live with families, right? And so they feel responsible for making sure that they don't actually bring it home, even if they don't show symptoms, right?
Yeah, of course, especially that they have little kids or you live with parents and is old enough to and very susceptible to COVID and everything.
Yeah.
So the next question is when the patient says no because you want to, of course you have to take care of your workers, and then the nurses also need to be protected as well. When the patient says no, how do you manage to keep helping them?
So there are a few different scenarios of challenges. So one is when the patients say no. Two, patients with really grave symptoms, their family decided to go back to the kampong and to the village. And three, families who needed care, and we know that they needed to go back to the hospital for chemotherapy, albeit for palliative reason. But the family has decided that it was too dangerous for them to get back to the hospital. So these are all scenarios that we needed to cope with. So let's take the first one. When patients actually say no, and the patient's family are too afraid for us to come, then as I said in the beginning, there was nothing we can do to actually break that impasse. And then we realized that actually, if we could navigate and make sure that we test them with the rapid test kit, perhaps there is a way that we could meet them outside, test them, and then we can start coming into the home with a mask and a face shield. And so those are some of the things that we're beginning to explore. And in some of the areas, though, like the child obviously have symptoms, or the family obviously have symptoms that are worrying, their symptoms, COVID symptoms, then I think we had to make the decision that they had to go to the hospital. The second type of patients are the patients who actually go back to the village, and albeit with, and sometimes with patients who are very, very sick. And there our nurses continue to call them, and we have started even getting the medications and transporting it and delivering them to the village. So some of these delivery costs for us have gone up. The only thing we can't deliver for patients is morphine. And that's the sad part, because for patients at the end of their lives, often we do need to provide morphine. But as healthcare workers, we're not allowed to carry morphine on behalf of patients. Patients' family need to be the one who actually come to the hospital and pick them up.
Yeah.
And some of the doctors don't even want to prescribe unless the patient is in front of them. And so these are some of for our nurses, really challenging, because it's sad for them, because they feel like, and when our patients are in the kampong, one of the things is, how do you carry out difficult conversation when we know that the final hours of this child is coming? How do we make sure that we provide ample support, sufficient support for the family? And our nurses have told me situations like they will say something, and usually these words are accompanied with touching the hand of the family members. Say, do you realize, or do you understand that, or can you see that some of the symptoms have actually grown worse over the last few hours? But these are difficult things to say when you're on the phone. And then when you're quiet, you usually want to be silent to allow the parents to talk. But here, the silence becomes really awkward because you're on a phone. And so these are some of the challenges. And then, of course, the final ones are the ones where we have patients whose family are refusing to go back to the hospital. And our nurses are having to actually turn out more often, witnessing some of the symptoms that are regressing really quickly. And yet we know that the parents are too afraid to go to the hospital. And try as we may to advocate for the child, we need to respect the patient's, the parents' choice.
Yeah.
So these, you know, these are some of the most difficult time for us to make sure that our nurses emotionally are prepared to navigate this situation. But also importantly, Sarah, from if we were to take ourselves away from the patient and the field level, is to actually be able to always have this feedback session with the team and say, what are the challenges that you're seeing? And how difficult is it for you? And when do you feel you arrived too late? When do you feel that you should have arrived earlier to a patient's home? And what are the challenges? What are the obstacles? Because sitting in our office, we need to be able to somehow troubleshoot for them. Because we are changing, we need to pivot all the time to make sure that whatever rules that we put in actually are rules that first and foremost are benefiting both the patients and also our nurses.
Okay. So it's like building a feedback loop where we try different protocols, and of course this has to be proceed with caution, right?
Yes.
And then after we do the protocols and then we see, oh, this doesn't work, this works, something else works best, and then we implement the new protocols and test it in the field.
And
But
have that feedback loop once
yeah,
again.
yes, and get feedback loop.
Yeah. So it's like when our nurses started returning to the hospitals with patients who are very sick, and they enter into the ward. And those were areas that we didn't want our nurses to go to initially, because as we said earlier, before we started, so many doctors are dying, so many nurses are dying. And so how do we know that the protocols in the hospitals are well implemented, and how can we let our nurses enter that area? So when we started mobilizing our nurses and allowing them to go back to the hospitals, and right after that, we came back into the office and we said, okay, let's talk about this. What did you see? How did you keep yourself safe? Do you feel safe? Did you feel that you were putting yourself at risk? And so we needed to always make sure that that conversation is live.
Okay. So there's also another question in the chat room, which I think would correlates greatly about the topic that we're currently talking about. So of course there are patients, parents who are afraid to go to the hospital, even though their children are very sick and need medical assistance because they're too afraid. And of course, there's also maybe patients' parents who doesn't let Rachel House nurses to come to them because they're also afraid. What if the nurses went to someone's house that's infected by COVID and other disease? How do you build the trust between these people? So how do you build the trust between the nurses and the patient's family? And then if the patients need to go to the hospital, the patients with the hospital, and then the nurses with the hospital as well.
Yes, I think that's the first and foremost, the most important oath that we had to make when we enter into this terrain of the pandemic. That again and again, of course, initially our team was afraid, but again and again, I needed to keep hammering home that our infection protocol works both ways. That we are keeping ourselves safe, but more importantly, we're also keeping our partners safe, our partner hospitals, and we're keeping our patients and their families safe. So if we fail to implement our own safety protocols, like you're not wearing your PPE in a dangerous situation, you're not taking it off correctly, you're not basically taking care when you're in the car, then you're failing not only yourself, but you're failing everyone else that you are actually going to come in contact with. And the most dangerous ones are basically our patients with low immunity. Yeah. So there is this agreement right from the beginning that we don't live for ourselves, we live also for everyone else that we actually work with and work for. And I think this is, the mission and the purpose right from the beginning, following that open conversation, is to say, what is our reason for being? Why are we here? We're here first and foremost so that we can be present for our patients that we know have no one else but us to look after them, because they are from the poorest areas. And for our patients to get to the hospital, they require 80,000 rupiah just one way. And it's 160,000, return. And they earn 20,000 to 30,000 rupiah a day. So for them, there is no choice.
Yeah.
They, so for a lot of them, we are their only lifeline. So if they need to go to the hospital, we pay for them to go to the hospital. So to keep people safe and to actually build that trust, I think trust comes from us first and foremost, behaving and knowing and understanding that we're not only keeping ourselves safe, but for others. I think by our actions, we carry that aura that we are here to also keep you safe. Now, the second thing is all of our nurses are given a script to explain why they come in with this full PPE to a patient's homes. Because initially, especially, it was like an overkill, right? Our nurses come in with the face shield, hazmat suits, gloves, and masks. And, for a lot of people is like, are you sure? And, our patients' homes are very, very hot because a lot of them have no windows.
Yeah.
And for our nurses, it's like dripping inside. But I think understanding that they're doing this for the patients, and they explain to the patient's family that we do this because we travel a lot to other patients' homes and we travel a lot to hospitals. We want to make sure that you are comfortable, and you are confident that we have the right protocol to keep you safe. So I think it works both ways, and it's also the aura. And for the nurses in the hospitals, initially they didn't see our nurses in a hospital, and there was for some hospitals they were like, where the hell are you guys, right?
Yeah.
And I think we tried to explain to them, look, we are field people, and at the moment we're still getting used to how we can keep everyone safe. So until we know our protocols work, we're not going to expose you.
Yeah.
Right? So we need to make sure that we learn how to do this, and then we get to the hospital again. So being open communication, I think, build trust.
Yeah. So one of the things that I also learned back in university, back when I was stationed across hospitals, and one of the things is that even though people come to the hospital, they have different level of trust or different level of, their trust in healthcare, basically. More like, especially in people with very, very terminal disease or people with very, very complicated case, usually they just come to the hospital just because they don't have anything else to do. It's not like some of them doesn't really have any will to live anymore. They're just like, oh, I'm just doing this because, I have no other choice. I cannot work. I cannot do anything. So I just come to the hospital hoping that they would cure my disease. But even though they don't, it's okay to me or something like that. And of course, this situation really have a great effect on them, on these patients, because they already had a very complicated case. They already have a very complicated disease, and then this situation happened, and it makes them more impossible to get treatment. Yeah, and of course, this will break the nurse's heart as well because they cannot do anything about it. They want to help, but they cannot.
Yeah.
Right. So how does Rachel House manage the situation? Because the situation brings a lot of stress, a lot of psychological distress, anxiety for the patients, for the nurses, even for the doctors they're trying to see in the hospital.
Yeah, that's a really good question. I think some of the most difficult situations are actually the situation faced by healthcare workers.
Yeah.
And especially by healthcare workers in an environment where we don't really know if it's safe yet, right? And I think I look at countries that have very, very strong implementation ability, and there I think the healthcare workers are better able to navigate this situation because they know what is dangerous, what is not, right? It's black and white because it's almost like the boundaries are very clear. In countries where the population is so huge, like in India or in Indonesia, where there is such people live in Jakarta, especially where people live in such close quarters, I think we are looking at situations where we don't know what is safe and what is not. We don't know who is safe and who is not, right? And this is where I go back to the only thing that we can count on is the person and the people that are within our immediate vicinity. Like within the team, there needs to be a really strong solidarity and trust that I've got your back, you've got my back, and that within the organization, we will look after you. And as soon as you feel at risk, you need to be able to come back and tell us.
Mhm.
So first, the safety must come from home. The safety must come from your tribe of people to know that I've got your back and you've got my back. Then it branches out from there to say, okay, who are the people we exist to take care of? Because now that we know how to take care of ourselves, we need to immediately go out there to make sure that those who are without help, we will help them. So it's like a hub and spoke, right? As soon as you feel safe, you need to be able to reach out. But that area initially, that circumference of care that you provide initially is still quite limited, because we only went to patients initially who are existing patients. We already know them. We know who they are. We know how to take care of them. We know the safety of their homes. So for the first few months, we really didn't take any new patients, and the hospital's numbers of patients who actually turn up at hospital has also dropped. So it's only now that we're beginning to go out and spread the net wider and say, okay, now we know how to do this. Let's go back out and look after people. So in answer to your question, Sarah, it's like, how do we make sure that our nurses are taken care of? Because there are instances where there is a heartbreak. There is instances where they feel like, how come we didn't get there? You know, like, or I couldn't get there faster for my patient, and I know that he had been in pain for the last 24 hours. Those things happen. And I know of at least 2 or 3 instances where our nurses really voice their distress.
Yeah.
But we needed to bring them back in and say, okay, let's co-design this together. If you know that there are instances that are actually heartbreaking for you, let's sit together, tell us how you would design this differently. I think when you bring in the field people who are suffering because they know that they could have done this differently, and to empower them to co-design a different structure, then you begin to actually be able to find a solution. And I think healing comes from the knowledge that you're doing something. Right. So I think that voice, the trust, and then bringing them back in and knowing that based on the purpose of why we're here, we're co-designing a different system as we continue to navigate a very uncertain time, hopefully will lessen some of these huge heart-wrenching moments for a lot of healthcare workers.
This actually can also help with, let's say, if they have PTSD, right, from seeing someone who's very close to them, but they cannot do anything about it because the situation is very hard for them to do. Because of course, when they try to help some other people, they try to help preventing this to happen again by making something different, by contributing to the newest Rachel House protocol, for example, by contributing to the different way of reaching out to patients.
Yeah. You know, Sarah, one of the things that I think is key to Rachel House when we started 14 years ago is that we value heart more than anything else. So anyone who comes into Rachel House as a team member, first and foremost, we ask them to bare their hearts. So hearts have to speak first. So during this time when it is heartbreaking for them because, you know, of whether turning up later than what they think was the past that they could do for their patients. These are the situations where sometimes I sit back and I look and I say, how do we navigate this? How do we balance this out? Because we've asked for our team to always lead with the heart. And yes, their hearts are breaking now because, you know, it's, as you said, PTSD it is a traumatic time.
Mm.
We have online training now. A lot of the doctors and psychologists who used to come from overseas and help our team, the grief therapists, are now running this online for some of our team. So Zoom has been a blessing for a lot of our team members.
Yeah. So because it's also interesting, right? How the situation can affect all of us differently. Some people
Yeah.
might not be just like, it's COVID, it's nap time, I don't have to go to the office anymore. It's
Yeah.
fun. But there are also people who's very stressed at home because they cannot go somewhere, because they feel that their world is now limited to a small room rather than, the whole office or the whole world.
I
So
know.
of course, it's very hard to navigate between balancing the emotional, uh, the balancing the emotional part of the nurses of the patients to keep it sufficient for them to still striving or still surviving through this pandemic.
We talk about Zoom making possible a lot of things, right? So I remember after a few weeks of working from home, we ran a discussion with our team and particularly the nurses and asking them, what is the difference? And they said, oh, we noticed, and being Indonesian, I think being Asian, a lot of them say, we noticed so-and-so had a really difficult patient last week. And we feel so bad that we couldn't be there for him. And each they would point each other out as to having difficult cases. What I realized then is, although they had a meeting every day online before they set off and take care of their patients, what they didn't have was the old days where they would come back to the office after home care, make a cup of coffee for themselves, come to the round table where they would all be typing their case notes. And then suddenly someone will say, oh, I went to see this TIAS, this patient, and it was really difficult. I saw this really heart-wrenching time. It takes them to defrag, have a cup of coffee, and then bring out the tragedy that they have just seen and witnessed. So those things had changed. And I think these are some of the things that we're now trying to find out. How do we make this possible for our nurses who witness some of the most heartbreaking stories? Like last week, I was listening into some of the conversation. One of our children's mother had been evicted from her home. So she's now sleeping with the child on the street, and our nurses have to take care of them on the street. And so these are the things that our nurses witness, and yet they have to go back to their costs, to their room, and face the four walls, and with difficulty of sharing.
Yeah, this is more like the different new normal experience for the Rachel House, of course, because of course everyone feels the stress that they have to stay at home, but everyone have it differently. They do their work differently, right? Especially if you're a healthcare workers, you come back not feeling sure about your patient, but you're also not sure whether you've been infected or not. You don't know. Yeah. So regarding the nurses' experience, is there any patients or family of patients or nurses even who has been infected by COVID-19 in Rachel House, and how do you make sure that they keep their well-being in terms of these even more difficult times, because one of their closest ones or maybe themselves is infected with the virus?
We had a child who one of our nurses had visited 4 days prior to her being admitted to the hospital with seizures. And so our nurses went to her home to change the feeding tube. So aerosol procedure, right?
Yeah.
And they were dressed completely in PPE, and they changed the NGT tube. But the child needed to go to the hospital because of quite a difficult seizure, and so the grandmother took her. 2 days after she was admitted to the hospital, she was tested positive for COVID. And so by that time, it was 6 days after our nurses had seen the child. And so we immediately sent our nurses for tests. At that time, we didn't have rapid test kits yet, so we sent them for tests. And thankfully, they are negative. Now, the question is, for this particular patient, 2 days after she was tested positive, they tested her again. And interestingly, her grandmother is tested negative.
Mhm.
She was tested positive. I think a few days after she was tested again, she was actually negative. So my question is, was that an error, erroneous results, or did she really have COVID? Another child living in a shelter right now was tested positive when he checked into the hospital with his mother. Once again, his mother was tested negative.
Mhm.
He was tested positive, but a few days after they repeated the test again, and he was tested negative then.
Mhm.
So 2 kids so far that was tested positive, and then a few days later tested negative. So those are the only 2 out of our patient population right now of 27. We started the pandemic with about 35 patients, and we've discharged some patients, and we've also, some patients are in Kampong, and some patients have died. So so far we don't have patients who, at least we think, are obviously positive. And those 2 who have tested positive, but a few days later tested negative, and so we are not certain.
Yeah.
I know tomorrow we're going to see a patient, and we're going to be testing this patient. And so we'll see.
Okay. So basically, it's more of a situation where maybe the patient have COVID, but of course the main point of these patients coming to Rachel House is not that one, right? Because they already have the terminal disease, or they really need help in terms of living the remaining days of their life. And like we already discussed before, this impacts the well-being of the nurses greatly, because they're heartbroken, and then the situation making them more difficult to work on that to help more people. But looking at the COVID situation right now, it doesn't only impact the psychological part of people. So maybe in big companies, they already laid off a lot of people, right? And not to mention maybe one of them being the patient's parents, or even the relatives of the nurses, right? So how do you manage the other aspects of the nurses' well-being, or your team well-being in Rachel House?
Good question. These are, it's like a double, triple whammy time, right, for many people.
Yeah.
So let's start once again with patients. So at the beginning of the pandemic, like this particular patient who went into the hospital with seizure, her grandmother washes clothes for people and for their living. And that obviously stopped because a lot of people were afraid for her to come. And so she needed even just basic food, right? For the first few months when the pandemic started. So we ended up delivering food. We ended up delivering basically essential needs like sembako, right? We had a patient whose father is a driver with the work from home situation. His employer said, look, because we don't need you, you can just stay at home and we'll call you when we need you. But in the meantime, we just don't pay you. And so that meant that, he couldn't feed his family of 5. We have patients' family who has a grobak and they sell food, and all of that basically stopped when there was a stay-at-home time. And so many of our patients' family lost their sources of income. And so that became a really difficult time. And especially if you remember, that was also Bulan Puasa, that was also fasting month, that was also Hari Raya. And it was just tragedy because it was a time when people should be celebrating. It was a time and that when, kids should have new clothes. All that didn't happen. So we literally begged. We went to corporations, we went to everyone to ask for people to send oil, cooking oil, rice, biscuits, everything. And we sent everything out to the patients.
Yeah.
So that's for the patients. And this has continued. We continue to provide a lot of food items on top of the medications and everything else, and masks and sanitizers. The other thing is our own team members, of course. There's been a few where their husbands have lost their jobs, and these are really difficult times. But we are a family, right? And so it is. I think there's safety in the sense that we know that whatever happens, we will look after one another. And so far our team is still intact in the sense of, we're maintaining the people. I always believe that as long as we can, as long as the patients are still needing us, we will do whatever we can to make sure that we will be around. It is not easy, because I think even if we say to ourselves that we will be around, our team is seeing left, right, and center people are losing their jobs.
So is it hard to maintain the enthusiasm in the will to keep helping people in the nurses, especially maybe if Rachel House have volunteers, for example? Is it hard to maintain the volunteers or look for new volunteers to help to make sure that the procedures in Rachel House to meet the patients, to support the patient, go smoothly?
I'll tell you a story that really, really makes me, it gives meaning to life. Last week on Monday, there was a fire in North Jakarta, and within a lot of the areas that our first group of kader, our first group of community health workers were actually trained. And Rachel House trains from 2014 to 2019, an incredible number of kader in North Jakarta to provide care for adult patients who are too sick to get to the hospital. And after the fire on Sunday night, on Monday, the team told me, and how I even found out was because they said, hey, are you okay if we give the selimut, the blankets that are in our office for some of these fire victims? And I say, where's the fire? And because the fire is within our neighborhood in North Jakarta, I quickly called a couple of friends who actually have soup kitchens. And this, within a day, the soup kitchen was mobilized to provide 350 packs of food. Now, it needed kader to come together to distribute the food. And our team basically called around to the old kader, and some of them live in the area where this fire is happening. But they showed up, 10 of them showed up. And without, any time, we told them the first day was 11, the second day was 12 o'clock, the third day was 4 o'clock. They were there to just distribute food. Sarah, it makes me feel like in the community that is the poorest, the gotong royong spirit is still very, very strong. I often tell people the story that some of our patients who have lost their parents, the next door neighbor will actually adopt the baby, even knowing that the baby has HIV. And it doesn't happen anywhere else other than in some of the poorest areas that we actually operate in. So there is an incredible solidarity among these communities that we have brought together. Does that give us spirit? Does that give us the enthusiasm? Does that actually maintain the spirit within Rachel House? I believe so. I believe that every day our nurses are out there seeing that they are able to lend their hands and lend their help to someone who has no one else. And for a lot of our nurses, they are the only lifeline to hope for their patients. When they come back, I think a slice of that hope that they've given to their patients return to them. It's like a slice of humanity, right?
Yeah. I guess even after all these, bad news all around us, and then big corporations driving or making some scandals, we have to agree that we still have a lot of good people among us, actually.
I think so. I think Indonesians have to be so proud of the fact that at the core of spirit of Indonesia is this incredible spirit of gotong royong.
It's really, really the solidarity is really, really tight. I read an article once about there's this family living in a small area, maybe not kampong, but like a big, quite crowded area in Jakarta. And then one family got the COVID, right? So there's one family, the father already died because of the COVID. And then the mother and then the small children needs to do self-quarantine in their house. And then the Ibu RT organized everyone in that RT to cook for them every day. So everyone takes turn.
This is it, right?
Yeah.
I think that sort of story needs to go out because, you know, in Singapore, when somebody's quarantined, the community service, not the people, the government from the community center actually delivers food. But I've just realized, because initially I was quite judgmental. I was like, why aren't people willing to be tested when their family member has actually been tested positive? I realized that if they were tested positive, who's going to feed the family, right?
Yeah.
And so I think when the community comes together and cook for whoever has been infected, and that's just such a beautiful story, right?
Actually, there's also 2 or 3 questions related to this current topic about the local community engagement we're currently discussing. So as we see that actually a lot of small communities or local communities help each other during this time, should the decision or should the management of the pandemic goes from bottoms up from the people or goes from the top and down, the government itself? Which one do you think is more effective, more reliable, or maybe it's easier for people to approach to and to get help from?
That's a question that I've always asked myself. And I think in the unique situation of where we are in Indonesia and who we are as Indonesians, I would say bottom up, right? I would say we have to first and foremost appeal to the goodness in everyone. Because if we do that, Indonesians are, at the end of the day, people who like to help one another. But fear makes it the separating factor, right? So if we can put that fear at bay and allow people to feel that it is safe to help one another, that there is a safe way of helping one another without exposing yourself, then I think we are stronger building from the community level than we are in hoping that the government will solve the problem. Why? Because we don't have enough hospitals.
Yeah, I agree.
We don't have sufficient, the puskesmas are basically inundated, right? But we can do it if within our community, we help one another and say, okay, that person in that household has just been tested positive. Instead of us running away from this person or wanting to evict them, what if we say to them, please, can you just stay at home? Don't worry, we'll deliver food to you. We'll pitch in, even though we're all poor together, but we can all spare one meal for this family, right?
Yeah.
And that you're not only saving them, but you're saving everyone else. Because if you don't deliver food, they're going to be coming out.
Yeah.
And they may infect people, right? But it's not out of their bad intention that they infect people, but they're also afraid who's going to feed us, right? So it's better when community actually help one another and say, tell us the truth. Tell us when you are infected. And it's only at a community level where truth and people have the freedom to speak truthfully without being evicted that we can actually hope to contain the spread of COVID.
Okay. So apart from the local community story on how they're helping each other, so how do you see the importance of government or with the upper top management people of Indonesia in terms of engaging with local communities? If you see that you feel that, oh, this is very important to do, there's a very important thing to do, how do you see the engagement be? Like, for example, maybe the government can provide guidelines, and then the local communities can actually do the handiwork to help the people who's infected.
So who are the most prominent people within each community? And I think, you know, in the early days of HIV, when we first started, I went to speak to Unilever, and the head of the CSR said to me, come and tell our group of, you know, employees about HIV, because at Unilever, we believe that every one of our employees are community leaders. For them to have been able to work at Unilever, they are by default, when they are in their community, they're community leaders. And if you teach our group of employees about HIV and how they shouldn't be afraid of it, how they can keep themselves safe, then by default, they will tell their community how to keep themselves safe. So let's go back to that. The biggest contributors to society today, positively or negatively, is up to us, are corporations. Right? And so so instead of the government, what can corporations do to make sure that they play a significant role in containing the spread of this COVID-19? I believe it's going back down to every community that you exist in and say, if community can come together and look after themselves and be able to willingly speak the truth and tell people, when you're positive, you stay home, but we will give you access to whatever you need. The community can come and say, look, we need maybe the support of a couple of meals that we can provide to every household when they are, you know, infected. And perhaps a corporation that exists in that community can say, okay, let's come together and pass the hat around and see how much we can spare every week to help people who are infected, right? It's only when we look after each other in the community, not just the individuals, but people who are actually salary payers, you know, employers. It's only when we go through that, when humanity exists everywhere at every level, then and only then can we expect our government to show humanity, right? Because I think often we don't even show humanity to our neighbors. So how can we expect that from anyone else?
Yeah. Sometimes we also forget to see that since the government is in a very top management of Indonesia, right? And like some people, like most of us, are at the bottom. We forgot that sometimes the people at the top can be out of touch with the people on the ground. They feel like they're making, I'm making a new regulation, I'm making a new law, I'm making a new instruction for you to follow so you can help yourself. But they don't see what's happening in the field, like you just mentioned, like the people who are infected with COVID is not going out because they want to spread the COVID, but they're going out because they're not sure, they're afraid that they cannot feed their family.
Yeah, and the daily income earners, they earn 20,000 or 30,000, right?
Yeah.
So in North Jakarta, one of our patient's father earns 30,000 rupiah as a nelayan, as a fisherman, right? And so when he doesn't go out to the sea, he doesn't get the 30,000 rupiah.
Yeah.
And so I think sitting around a table, unfortunately, making decisions usually for the masyarakat, for our citizens, are people who have never been to the field.
Yeah. Yeah.
Or maybe they did, maybe 30 years ago or 20 years ago.
Yeah, maybe they did, but probably they forgot they don't know what it feels like right now.
And then sitting around them are people who feed them the information, who may not actually who may not be exposed to the people. So I think this is the time when all of us need to play a role. This is a time when humanity needs to come back to all of us, and we have to say, you know, because I think COVID-19 is an equalizer. If I don't save my neighbor, I will be infected, right? And so how can I make sure that everyone know that it's hands on deck, right? All of your cards have to be there, and that we all have to be able to trust one another, right? Because it takes only one bad apple when we're, you know, it's basically a game changer, right?
And regarding the communities, because the community help people, right? And usually the local communities is stronger in bonds or in solidarity. Should offices or bigger corporation do the same thing like what community did? Because of course they have different mindset in mind. Community is like, oh, I'm helping a friend, I'm helping my neighbor. But however, in a corporation, they have business and profit and other tons of stuff to be considered.
That's a really good question, right? Because, I just recently read a book called Humankind. It was recommended to us by Paul Pullman. And there they talked about during the wartime,
Mhm.
it's, the strongest battalion are not the battalion that run on strategy, on propaganda. They are the battalions who are brothers in arms, who knows that I will not fail my brother and I will make sure that no matter how sick I am, I will go to the battlefield because I don't want my brother to die. And this is where you get the strongest team of people who can come together, come hell or sun or rain or sun, you will actually be able to toughen out and you will navigate the roughest waters. So when we apply that situations to corporation, then I think, or what Rachel House is doing to corporation, then I think we have to ask ourselves, do we even know as employees of a corporation, what is the sole purpose, the reason for being? If we know that, then there is a reason to navigate, for us to all come together and say, we need to navigate this.
Mhm.
And the second thing is, do we trust one another? Do we trust our employers to basically have our back? Right? Is there sufficient trust that has been built over time for us to know that, you know what, I'm going to go the distance on this one because I know that there is a strong bond and there's a strong reason and there is a really convincing purpose for me to be here and to ride through the rough waters. So I would go back to ask ourselves, in order for corporation, what would it take for a corporation to navigate this and for teams within the corporation to work together as a community rather than for a profit motive? Profit is not bad, but what is the one thing that would be bigger than all of us put together that brings us all together and to navigate this rough water? It's got to be a higher purpose. Unilever's Lifebuoy, Unilever's first product is Lifebuoy. Lifebuoy was actually created so that children would not die, and it was for the hygiene purpose. And how many organizations started with a very, very strong purpose and strong product as their purpose, but today, having grown through many, many decades of success, have lost that original sense of purpose? Has the pandemic given us an opportunity to navigate, to pivot back, or to pivot to something higher than profit? Maybe it should, right? Because we hear about climate change, we hear about everything, right? But how can we make sure that every day of our time as employees serves a higher purpose than simply that bowl of rice that we're going to bring back for ourselves, right? Can a bigger purpose that serves the planet and the people that we work with bring us together to actually be able to survive and survive this pandemic successfully?
I think that also makes some of the brands that came to top of mind because they actually, let's say, put commercial that looks that they engage more about the people, and then they release a product that really fall close with the people or with the customers, not something that they sell like, oh, this is important, this is very good, but they're actually selling something that can be relatable by the customers, by the customers. So actually that brings us to the last question, since we still have lots of questions actually, because this session is very, very interesting. Thank you for coming here today. Do you have any, would you be able to give any closing statement on your take of how to adapt in pandemic situation?
You know, I've been thinking almost daily now, what is what are the lessons that I'm learning since from the beginning of the pandemic?
Yeah.
Because, you know, there's so many lessons and they come in blows, right? And it's so easy to capture it one day and then forget it and then probably make the same mistake again. For me, I think the pandemic has been a clarion call, a really, you know, almost like the bell that rings so loudly that business as usual in the past can no longer continue. That the purpose for a lot of our living had been this incredible consumerism sort of society that we consume, and we've been asked and we've been convinced that we will need to purchase in order for us to elevate our status. But there came a price, right? A price of us forgetting what is the essence of my being. Who am I? Who am I without all of the purchases that I want to make? I think pandemic has actually trained us really well in saying, you really don't need a lot. If I can turn up for meetings with a shirt at the top, but my pajamas at the bottom, that shows that actually my being, my presence is probably more important than what I'm dressed at. So my takeaway, I think, from this time of, you know, navigating and helping Rachel House through this time is, first and foremost, the currency of trust between one person and the other is probably the most important thing for us to have during this pandemic. Whether it be within the company or within a community, that currency of trust needs to be rebuilt. Or between a consumer company and their customers, right? Because that's lost. Between a doctor and a patient, that's lost. So how can the pandemic bring us the opportunity and the wake-up call to actually build that currency of trust and bring back trust as a core reason for our interaction between one another? And then it's only when we have that trust between one another that we can talk about what is the purpose of us coming together and to collaborate. Because without trust, there is no collaboration. Without trust, there is no bringing together people to actually navigate and to drive the same car towards the same goal. And it's so much harder during this time of pandemic to bring people together to work through the challenges if you don't have that trust. So trust between any one of us, trust between corporations, trust between a corporation and employee, I think is the currency that we need to bring back first and foremost. And then, only then, can we actually ground the purpose and the reason of why people must come together and can come together to work towards a common goal.
Yeah, so that is a really, really good closing statement. So if I may summarize a bit, from since 7 p.m. we've been here talking about the pandemic, talking about adapting, and also your experience in Rachel House, we see that if we want to make changes, if we want to do something different, then first we have to start with empathy. We have to be able to see a different situation with different perspective. We have to be able to put ourselves in other people's shoes. Like, for example, in the patients in Rachel House, we have to be able to put ourselves in their shoes, where they are scared of the people coming, being judgmental because the Rachel House nurses wear all top to toe the PPE, but they're also scared to go to the hospital because the chance of them getting infected is very high. And then after we gather the empathy, after we get in touch with the empathy, with the perspective of the people, we need to define and clarify about the purposes, the main purpose that why we are doing this. Like, for example, the nurses in the Rachel House, their purpose is to serve their patients. So even if it comes to them that they have to do it online, they have to do online consultation, whatever the process may be, the purpose should be to help the patients, to serve them, and to build trust, to walk on that foundation of trust so they can treat them better, so they can help them better. And then after that, only after that, we would be able to co-create on the protocols, on the ways for all of us to navigate between the challenges, between the complications, in order to finally help other people and to reach our main goal. And after that, would we be able to get learnings and get feedback loop so we keep improving. So thank you so much for everyone who came to our session today. Thank you so much for Lina from Rachel House for sharing lots of really, really wonderful insights, really good informations and inputs on and feedbacks and enlightenments for us on how to deal with the pandemic situation. How can we see this differently? And of course, not to mention how to keep helping others, even though we're also in limitations. But even in this pandemic cannot stop us from being good people. So thank you so much for everyone who come today. We will send you the presentation today, and of course, we also have Lina's Rachel House contact information. So if you're interested in volunteering or if you're interested in collaborating with Rachel House, you can easily contact the Rachel House team, and of course to help other people and bring others their own purpose of life. So thank you so much for today. See you on the next session.
Thank you, Sarah. Thank you, everyone.
Yeah. Thank you, Lina, for joining us tonight. It's a really, really wonderful session. Okay, so see you on next Tuesday. Sorry, see you on next Wednesday.